right now. Terrific. Thanks, Dan. Well, again, thanks everybody for joining. I'm just going to go around and start with introductions so everybody knows. So and just by way of background, if you haven't been able to keep track of all of it, so Governor Mills appointed an AI task force back at the end of 2024, which includes people from multiple sectors. The core members of this work group are taken from that overall AI task force. And I'm going to introduce them first, or ask them to introduce themselves. Mary?
Hi, I'm Mary Dickinson. I am the Executive Vice President and Chief Scientific Officer of the Jackson Labs. I joined JAX about a year ago. I come to JAX from the state of Texas, where I was the Senior Vice President and Dean of Research at Baylor College of Medicine for 5 years prior to moving here, an Associate Dean for Research before that, and a faculty member at Baylor for 19 years. My research is all in mouse genetics and human disease mechanisms related to rare disease. But during my time at Baylor, I spent a lot of time leading our clinical research groups, as well as the basic research groups, and also being the IO for human subjects protections and all that kind of stuff. So I'm really excited about this task force because we did so much to try to push AI into the clinical research realm, and I'm just excited to work with all of you around.
Great. And Mary is also co-chair of the overall Governor's AI Task Force. Right? I said that right? Yes.
That is correct. Yes. Thank you.
Okay. And Chris?
Everyone, I'm Chris Mallett. I'm the Chief Administrative Officer at Northeastern University's Rue Institute in Portland. I've been in Maine for a little more than 5 years, coming on 6 now, to help establish and run the Institute. And a member of the broader task force. And with respect to this particular working group, I'm excited to represent some of the great work we have happening at the intersection of life sciences, human health, and technology, and specifically computational methods as applied to those things. Good to be with you all this afternoon.
Great. And Dan?
Which?
Oh, I'm sorry, Dan Nygren. Yes, you. Sorry.
Hi, everyone. I'm Dan Nygren. By my background, you can see that I'm from Maine Health. I'm the Chief Information and Digital Officer here, a position I've held for about 4.5 years now. Prior to that, I was doing the same role at Boston Children's Hospital down in Boston. I'm a clinician by background. I'm a pediatric endocrinologist, and thrilled to be participating in this group. It's an exciting time within healthcare, for sure, as these technologies are absolutely penetrating what we do, as Rebecca will tell us later this morning, or afternoon, I guess we are.
Great. Thank you. Yes, I'm sorry, I neglected to note there are 3 Dans. Dan is one of those names that crosses generations. Lisa, if you meet a Lisa, they're all my age or older, but the Dan keeps going, so thank you. So I'll introduce myself just as another member of the AI Task Force, Lisa Letourneau. I'm an internist by background and currently serve as a senior advisor in the Commissioner's Office at Maine DHHS, where I support several different areas, including rural health, which is really one of my big interests in the AI area. And then we have several invited guests because we thought it was important to bring in people from the field who are really directly engaged in this work. So we have Dan Carteret.
Hi, everyone. I'm Dan Carteret. I'm a second-year Master's in Public Policy candidate at Harvard Kennedy School. And this year I've been working for a capstone project as part of that program. I've been working in collaboration with Lisa, looking at some of the potential opportunities for AI-augmented healthcare technologies to help address rural healthcare capacity issues in Maine. And prior to that, I spent the last summer working with Dan Matz and Scott Kleinman and GoPIF, looking at some of the opportunities and challenges around AI more generally for the state, both in terms of state service provision and just generally for the workforce, economy, et cetera.
Great, thanks. And Dan's going to be talking today about that report, and I did attach it to the meeting invite, I believe, so you've got that. Rebecca?
Hi, thanks for having me. So I'm Rebecca Hemphill. I'm a practicing internal medicine physician and the Chief Medical Information Officer for Maine Health. And I've had the great fortune to be spearheading our ambient listening project at Maine Health and I am excited to share that with you. I've been at Maine Health for over 25 years. Yeah.
Great. Well, thanks so much for joining us today, Rebecca. And you can't talk about ambient, whether we call it listening, documentation, scribing, without Rebecca's name coming up in 5 minutes. So we're really privileged to have her here today. Thank you. And Danielle.
Also get called Daniel from time to time. So another Dan.
Another Dan.
Or Diane or whatever. Thanks, Lisa. I am Danielle Lauder. I am co-director of U.S. programs at MCD Global Health, but more with my Northeast Telehealth Resource Center hat on. I've served as director of this HRSA OAT-funded program for, gosh, over a decade now. We serve providing technical assistance training, et cetera, to the 6 New England states and New York, but have worked with Lisa and many, many others around telehealth integration and expansion here in the state of Maine for many years, since way before it was cool, I think. And certainly AI has become a fixture in our conversations around telehealth and the needs that folks and ideas that folks are coming to us with. Make it a really important topic area for us to stay in tune with, and hopefully to be able to provide resources to our constituents here in Maine and well beyond. So thanks.
Great, thanks for joining. And Sharon.
Hi, Sharon Stanley. I'm the Director of Operations Improvement at the Maine Primary Care Association. I also manage our Health Center Controlled Network grant through HRSA. And so this is the grant that the federal government issues to help FQHCs optimize the use of their health IT. So this is where AI comes in and its interaction with EHRs and improving workflows and patient and provider satisfaction and that sort of thing. So I am bringing sort of that primary care perspective for AI and how it's being utilized and can be utilized in most of the rural communities we have here in Maine.
Terrific. Well, thanks, Sharon, for joining as well. Thanks, everybody. And we are going to hear both some, specific overview of what's happening in Maine. Rebecca's going to give us an overview of her work, but we really need to start out by being clear about our charge as a work group. And that charge has been set by the overall task force. So Dan Matz is going to give us an intro / reminder about that.
Yeah, thanks, Lisa, and really great to see everybody here this afternoon. And really excited to kick off this conversation. I'll be very brief, but just wanted to do a little bit of level setting right at the very top here about what this work group is really intending to produce by the end of our time together. As many folks know, and for the new folks, I'm happy to fill this in. Our task force is charged with delivering recommendations to the governor and to the legislature on how to respond to the implications around AI for Maine's economy, workforce, people, and provision of public services. And that series of recommendations is due by the end of October. So in the sort of working backwards from that due date, we have broken out into these subgroups here. This is one of 6 groups that is currently holding meetings much like this one on a wide range of different topics. And we imagine, and you will have, many folks here will have on their calendars 2 extra meetings beyond this one. And we imagine that by the end of those 3 meetings here through the end of July, this group will help produce a sort of set series of recommendations for the larger task force to incorporate in with and sort of debate and consider as they sort of go about crafting their final recommendations. This is not meant to necessarily, what this group does not need to necessarily worry about is getting every word right, every period in the right place, every sort of I dotted. It really is about generating ideas that are going to be really valuable for Maine and for Maine people to improve health outcomes and improve the lives of the folks that we're here to help. I'll put this in the chat in just a minute, but our guiding questions that you will have seen in the documents that Lisa have submitted really try to ask and get at exactly those kinds of things. And we are hoping to basically generate a list of some potential answers to some of those guiding questions as it pertains to AI and healthcare here at Maine. I'll also definitely, important to put in a plug here that we are having another sort of larger public task force meeting with the entire group 2 weeks from today And special thank you to Dan Nygren for helping to set up. It is a hybrid meeting, our first sort of in-person opportunity at a Maine Health facility in Portland. Really excited to get the chance to see many people in person who I've been talking to virtually over the last 6 months or so. So these topics will come up again in a couple weeks with the whole group, and then over the course of the next couple of months with this sort of smaller subset here, and with the goal of producing something that can eventually end up in front of the governor and the legislature around these topics. I think that's it. I'm happy to. I'll be here the whole time. Happy to answer questions now or offline on the charge and on the bigger pictures here. But otherwise, I think Lisa, I'll turn it back to you.
Great, thanks. And so I did put those guiding questions in the agenda just to again frame up the discussion as you're thinking as we're hearing some of these discussions. So, but with that, feel really fortunate to have Dan Carteret here and share the work that he's done, as he mentioned, really looking at the current use of AI, particularly as it could potentially be used to help address issues related to rural healthcare. So Dan has been a diligent student over the last several months. Are you done now, Dan? Are you totally wrapped up?
I am done. I am
All right.
assuming they sign off, I graduate in like a week. So
Excellent. Well, congratulations. And thank you for joining to share. And again, I believe I attached his report to the meeting invite for more background. But I don't.
And
yeah.
I'm gonna pull up some slides if that's okay. Okay. Are those visible? Okay. Great.
You want to go to presentation mode?
Yes, I will. Okay. Everything looking okay?
Got it. Good. Thanks.
Great. Okay. So I've already introduced myself, so I'll jump right into things in the interest of time.
So it's me,
yes.
but did everybody else? Is it just like suddenly? Is it just me? It suddenly like expanded, so I can only see a portion of the slide. Is it just me?
I think it's just you, Lisa.
Oh, okay. I'll figure it out. I'll just figure it out. Don't worry about it. Sorry.
Okay. In terms of background for this project, I imagine that everyone on this call is likely to be familiar with this, at least in some sense. But just as a way to get into the discussion, I'll just do a quick summary. Maine is the oldest and one of the most rural states in the country, and as such, faces some fairly unique challenges in delivering quality healthcare to its population, especially in rural areas. These challenges are, currently and projected to move forward to be exacerbated by the fact that the clinical workforce is also aging at the same time. So there's likely to be a significant increase in retirements in the workforce without a balance in terms of the pipeline of new entrants at the same time that there are rising healthcare needs. And of course, there's also been rising interest in AI augmented healthcare with recent developments in generative AI and machine learning. So with all that as background and motivation, the project that I've been engaged in over the past several months has been trying to answer a set of sort of motivating questions. And really at the center of this, the question is whether or not AI augmented healthcare technologies could plausibly make what I'd call a marginal but meaningful difference in terms of helping to address those rural healthcare capacity needs, particularly in primary care and hospital settings. And if so, what technologies currently appear to be the most promising, both in the short term and then the medium term? And what steps might the state be able to take to support successful adoption of such technologies? In terms of my approach, so I really the real centerpiece of the work that I've done has been engaging a series of semi-structured interviews with 17 individuals, mostly representing organizations around the state of Maine, including some people who are on this call right now. So I really appreciate everyone's time and expertise and knowledge that they've contributed to this project. And then I've complemented that with a targeted literature review, and I've also done a quantitative analysis that I'll talk about in a little bit more detail later. But just as a preview of that, what I tried to do is basically through essentially a back of the envelope type estimation or calculation, get to a plausible estimate of what the sort of potential capacity benefits could be in terms of primary care providers, effective primary care providers, of widespread adoption of a single promising technology, or a single promising use case of AI augmented healthcare technologies and across the state. Okay, so I really want to spend the bulk of the time that I have here, and I'm going to talk for a few more minutes, and then we'll leave some time for discussion. I want to spend the bulk of my time summarizing some of the prominent themes that stood out from the interviews, the conversations I was able to have with people around the state, and also some potential policy recommendations that came out of those conversations and the other work that I've done. So in terms of themes from the interviews, I'm just going to start by highlighting what appear to be the most promising technologies and applications. So really, the first one, the first and foremost one here, which I'm not going to go into too much detail on because we have a whole other conversation set on that coming up next, is around ambient dictation or ambient listening or ambient documentation. It goes by multiple names. But I think I just want to highlight a couple of points on this here, just because it'll be useful for some of the other things that I have to say on my end. So one is ambient dictation. I think everyone I talked to at an FQHC or critical access hospital had at least engaged in some level of initial piloting or exploration around ambient dictation. So this is not just happening at some of the bigger integrated health systems in the state. This is something that is really under active exploration across the state, but the degrees of sort of progress in that are significantly varying. But really, I think a lot of the excitement around ambient dictation has to do with its potential benefits for clinician quality of life in addressing burnout, and potentially also factoring into recruitment and retention advantages for organizations that could lean into that. And I'll talk a little bit about sort of how I see that element of it in a little bit. The second area of promise here that was discussed at least by a few subjects were the use of AI technologies to help facilitate interactions with insurers, things like prior authorization. So this is, I would say, in terms of the areas I've highlighted here, my impression is that this is sort of a distant second in terms of active engagement and piloting, but there is some active engagement and piloting here, especially among more sort of leading edge organizations on this front. And the idea here is basically to use generative AI tools to help reduce the administrative burden associated with going to insurers to get approval for procedures. You might have, if this is an area that's newer to you, you might have seen news coverage about the potential for like an arms race in this area with insurers and healthcare organizations essentially going back and forth and leaning increasingly heavily on AI technologies on this end. So that's something to keep an eye out. The third area that I would say is more sort of in the excitement and early exploration category, rather than necessarily significant adoption, is predictive monitoring, diagnostic assistance, and triage. I know, for example, or my understanding is that Maine Health and Rue Institute have collaborated, for example, on looking at predictive monitoring for potential deterioration among cardiac arrest patients in the state. But in terms of the primary care setting, again, I'd say this is more of like an early area. And then finally, integration with telehealth. And I think in particular, the two areas there are remote patient monitoring, and then potentially also, generative AI type chatbots to allow patients to sort of engage directly in terms of answering their questions and getting to the right level of care that they need to from there. So again, triage. Some other areas of themes from the interviews. I think one thing that was really valuable in these conversations was highlighting some of the potential, I would call them both enablers or barriers to successful adoption, because they're really two sides of the same coin, whether or not you have these items in place or you don't. They could be either enablers or barriers. One of the things that really stood out in terms of talking to FQHCs and really contrasting their experience, particularly with ambient dictation versus perhaps some organizations that have been able to invest more in their electronic health records, is that the quality of the underlying EHR system that is being used is really a significant potential enabler barrier to adoption, particularly on the ambient dictation front, but also likely for other use cases of AI augmented technologies. So, higher quality EHRs are likely to be better integrated with ambient dictation software. They're likely to sort of make more mistakes, and users of that technology need to spend less time sort of checking it over and making sure everything's in the right place. Whereas if you have a more weakly integrated connection between the EHR and the ambient dictation technology, some of the potential time savings in terms of documenting clinical patient experiences might be eroded by that lack of integration. Second area is the need to have to basically have high quality change management in place for what will be changed in the clinical workforce with use of these new technologies. I think one comment that really stood out to me was someone talked about the importance of seeing immediate results. If you're asking clinicians to interrupt their current workflows, it's really important to be able to prove the benefits to them very quickly for there to be buy-in. So there does need to be, I think, a significant state of readiness to some of these technologies before you want to launch with them. And then another element of potential constraint is lack of individuals with sufficient training and skills to actually do just the IT support for major upgrades. In particular, one leader of an FQHC or critical access hospital, I can't quite remember which, said that if they were to do a significant upgrade of EHR, they might need to temporarily double their IT support staff to support that upgrade. And there might just not be sufficient people in place in rural areas with the requisite skills and training to actually support that work. And then the last thing I'll highlight here, I'll skip over the forms of risk for now, but I'm happy to go back to it later. But there does seem to be a real trade-off between patience and expediency with respect to adopting these new technologies. On the patient's front, if you wait longer to invest in some of the adoption, you get more knowledge in terms of what's effective, what's not, what the high quality vendors are, and what's not. The technology will continue to evolve and improve. And there's also likely to be a race to the bottom in terms of cost of vendors of things like ambient dictation and other AI augmented technology. On the expediency front, I think first and foremost, I think we'll see later that use cases like ambient dictation can make an immediate impact. So that's in favor of expediency. But there's also, I'll discuss in a minute, there's also likely to be some advantages with respect to clinician recruitment retention that you could potentially capture in the short term that are likely to erode in the long term as more and more healthcare organizations across Maine and also around the country adopt these technologies. So basically any advantages you have from being an early adopter are likely to eventually be arbitraged to zero. But in the short term, you might be able to get some gains in terms of recruitment and retention. And then if there's an incumbency advantage in terms of retaining existing clinical staff, you might be able to maintain some of those advantages in the longer term. So just quickly, in terms of the quantitative analysis I did, as I said, this was basically a rough back-of-the-envelope calculation. But under a plausible set of assumptions in terms of the time savings from use of ambient dictation for clinicians, and I would say a very conservative assumption in terms of how those gains would be divided between the surplus created by those time savings would be divided between the clinicians themselves and the healthcare organizations they work for in terms of seeing more patients. It's possible that if this technology were adopted across the state, it could lead to essentially a 5% gain in effective capacity, or the equivalent of adding 86 new primary care providers in the state of Maine. Again, I mentioned there's sort of, as there is a short term, there's sort of a trade-off between patience and expediency with respect to adopting these technologies. There also is a trade-off between using the time savings from adopting some of these technologies for short-term capacity enhancements. And by that, I mean seeing more patients, adding to the workload of clinicians, and the longer-term gains that you would enjoy from reducing clinician burnout, recruitment, and retention. So I think it's important to be careful about not leaning too heavily from any gains that are seen from this technology on the former of those benefits, because it will come at the cost of the latter. But again, this is a pretty conservative estimate in terms of how that division is allocated here. And I'm happy to go into more detail about that too, if that's desired in discussion. Okay, so finally, just to close out, I'll go through a couple of recommendations. I think that the biggest thing in terms of a role for the state that it could play is just really tackling some low-hanging fruit with respect to facilitating peer-to-peer information sharing around some of these technologies. So there was, I think a lot of people I talked to expressed really just, this is such a new area, and there's a lack of in-house expertise with respect to, say, vendors for AI augmented technologies. It'd be really helpful to know what other healthcare organizations in the state are using and what their experiences have been. So one idea for that would just be to create something as simple as like a shared spreadsheet or a wiki for people who are sort of in charge of this rollout at different organizations, to explain sort of what they've done so far, what they piloted, maybe mention what vendors they used, and list themselves as a designated contact available for peer-to-peer conversations. This would allow that sort of direct connection, so organizations could learn from one another in terms of maybe what vendors are more promising, what are less promising, what sort of some of the process improvements that are most beneficial are. But that would also keep the state from having to maybe endorse any specific vendor or develop tremendous in-house expertise in the short term that might be better left to the people who are working specifically in these fields.
Hey, Dan, I'm just
Dan,
I'm just going to a little time check. So we're
Yeah.
close to your time. We'll go a little over. I think we can kind of squeeze on the discussion at the other end.
Yep.
But if you could put into wraps, we get at least 5 minutes for
Sure.
questions. Great.
Absolutely, yeah. I was gonna say that's the biggest one. The other one I think I just want to highlight really quickly is to the extent that information barriers could be lowered by developing or curating standardized guidance around some of the governance practices and also just provider use of new technologies. I think that would be a big help. So just things like emailing best practices for standing up an ad hoc AI augmented healthcare workforce or working group within healthcare organizations, how to go about piloting new technologies, guidance around contracting with vendors. So one thing we heard is that short-term contracts would be particularly useful in this domain because there's this race to the bottom in terms of costs and because the technology is evolving so quickly. But some of those basic practices might not be completely known around the state. And I'm happy to talk about other ideas there. There are more in the report, but I'll leave it there and leave some time for discussion.
Great. Thanks so much. You could, that was great, Dan. You could take that down. We can just open it up for some questions, reactions. Really appreciate the work that you did to talk to so many folks and summarize for us. But open it up to the group. Dan Nygren.
Hey, Dan, that was great. Thank you so much for that. You distilled it down really, really well. On the recommendations side of things, it's interesting that you mentioned that sort of information sharing aspect, because that was a stark realization that hit me when I moved up from the Boston environment, where there's such a density of healthcare organizations, and there was a really pretty good peer-to-peer sharing that occurred down there. And I found it absent up in Maine when I arrived, to the point where I actually reached out to a lot of other Maine healthcare CIOs. And frankly, I've expanded it now to Northern New England. And it's been really beneficial. It's super informal. It's literally a Teams meeting with a bunch of the CIOs, and we get together quarterly and we just shoot the breeze, basically. And obviously one of those topics that's top of mind now for us is AI. And we've done exactly this kind of information sharing that you mentioned. Even better is that we've realized that in many instances, it's not just the CIOs who need to connect, it's our teams. So Rebecca routinely now communicates with her peers, whether it's at University of Vermont or other health systems within Maine directly. So I do just want to underscore that peer-to-peer sharing is incredibly important as we all sort of figure this stuff out as we go. It's new for everybody.
Great,
Dan, I think
thanks.
that's really cool. Can I just ask a follow-up question to what you said? How large is your peer-to-peer network, and does it extend, like how far do we have to go to kind of balance out the needs for Maine?
Yeah, I think it's not exhaustive by any stretch. I started with, the biggest organizations and use that network to help me figure out where I had gaps. I think it's roughly about 10 of us who are on the distribution list. We routinely have anywhere from 4 to 7 people turn up, so it's not jam-packed every time, but still incredibly valuable though. And we've all
And
got
it's-
each other's emails too, so sometimes it's as quick as firing off an email to a peer or to that group.
And it's
Great.
Maine, Vermont, New Hampshire, like how many
Yeah,
other
yeah.
states?
We didn't go down into Massachusetts. It's
Yeah.
those 3.
Great,
Sorry to
thank you.
interrupt.
No problem. I saw Sharon and then Danielle.
Thank you. Thank you very much for that. I did want to say that I do think there's a lot of value in sharing just experience, right, with uses of product. I would love to hear from other provider groups about what they're using. We do, through our EHR peer groups, do a lot of peer sharing. So one of the things that's happening with FQHCs is they're really looking to their EHR vendor, right, for what products they're going to be building into their EHRs that are AI ready. And I think a lot of that is, there's a built-in trust there already with the product line. That's why they are using that EHR. They also have cybersecurity issues, right? That this makes them feel more comfortable with using their own EHR. But I think that they would love to know if there are products out there doing it better, right? Or that would be more useful to them. And the EHRs certainly don't do all of the things that AI is capable of. So I would love to be part of any information sharing on experiences. I'm certainly happy to share what's going on within the FQHCs in the ways that they're utilizing AI through their EHR vendors with the group. But I think that sharing of information would be really valuable.
Right. How do we do that more broadly in Maine, perhaps? And then Danielle, and then we'll transition to Rebecca, though we'll have more time for discussion more broadly at the end.
Yeah, it's just reiterate everything that's been said so far. And there's a lot of peer learning going on. And particularly, I know Sharon and I tend to focus on how do we reach the folks that may not have the capacity to participate in some of the larger conversations. So again, would love to help facilitate. We actually have a telehealth leadership forum that meets every other month for all 7 states that we cover. So we could potentially bring in some additional brain power to that. Rochester is one of our partners that we've worked. They do amazing things from an innovative perspective and could probably bring a lot to this conversation as well. But then, yeah, how can we get the best bang for the buck for everybody that's starting to pull together and work on this and bring the minds together is kind of one of my big questions. And then all of the recommendations that Dan came up with based on these conversations are directly in line with the types of questions and requests for help that we're getting. So for example, what could be some of the guidelines that we're recommending? So I think we're on the right path to creating resources that are going to help folks moving forward. So thank you.
Great. All right. Well, thank you. And with that, we'll keep going to Rebecca. What's it like to use this?
Great, thank you. Yeah, so let me share. I do have some slides. And let me share. Can you see my screen?
We can. Perfect.
Okay, great. So I'll just start by saying that this whole Ambient project is probably going to be one of the more memorable projects of my informatics career, just because of the impact that it's having and the pace. And it's really been a joy to be a part of this project. So I thought I would start just to level set because I wasn't sure how knowledgeable all of you would be about exactly what this means. You know, what is this ambient listening? How does it work? So I thought I would just describe how it works. And I will say I do still practice, and I am a user of the technology. So the bottom line is, as I walk into the exam room, I have my iPhone in my hand. I get consent from my patient before I get started, and I put the phone on the desk, and I basically forget about it. And then I can take my hands off the keyboard and face the patient and talk and have my visit. And so I have the conversation with the patient. The patient describes their pain. During the exam, I might verbalize portions of the physical exam. That's the green part, is the provider actually describing the findings of the exam. During the conversation, the patient might point to a part of their body that their left arm hurts, but they'll point and I'll say, so your left arm hurts, and I'll verbalize it so that it's captured in the recording. The AI generates the clinical note, which goes directly into the EHR. And the critical step is that before there's the final signing, I do a careful review of that output, do any edits that I might want, and then sign the note in the EHR. And as has been noted before, these ambient vendors have partnered with the EHR companies to really integrate in the EHR and in the workflow. And in our case, we're on Epic for our EHR, and the ambient tool is integrated in what's called Haiku, which is the iPhone app. So it's Epic on my iPhone, and so I can log into Epic on my phone, choose the patient I'm seeing, basically click record, and then on my desktop is where I do my review and editing. So that's kind of the mechanics of how this works. And you know, when I get a little bit later, I'm certainly happy to answer any additional questions that you might have with regards to that. So Maine Health we started our ambient journey, I want to say 2.5 years ago, at least. And we started with another vendor with a small pilot, rolled it out. The results of that pilot were very favorable. We rolled it out more broadly. And then as we were approaching the end of our contract with that vendor, it gave us the opportunity to sort of do a scan of the marketplace and identify another vendor that was very competitive, actually through my conversations with my colleague at UVM. We did a little bake-off and did an evaluation of that other vendor and ultimately decided to change vendors. And so as you can see, we're in the midst of the rollout of the vendor that we're on now is called Abridge. And so we're sort of doing a rapid rollout across the health system. I will say that we have planned a rollout in the ED. That will be happening over the summer. And we're actively working also on a pilot of use of ambient for our inpatient nurses as well. So this is not just focused on the ambulatory setting, though that is where we are all starting. We're actively collecting data and developing dashboards to demonstrate the impact that the tool is having. On the left, you can just see that our rollout has been brisk, and we have close to 300 users currently, and another 150 planned over the next few months. And so as we've sort of reached a tipping point in terms of word of mouth. And, every day we hear from people who are interested. This is no longer a technology that we're having to push out to people. This is a pull. People are wanting this. In terms of impact and sort of measurable data that we can demonstrate, I would say we're still a little bit early with our with the new vendor. But at the top, one of the things that we have the ability to do is to capture in a reporting system a number of metrics on EHR utilization. And we've been able to tag all of our ambient users, and we're already seeing about a 15% reduction in the number of minutes per day that the providers are spending on writing their notes. And this is all of our ambient users, primary care specialty. And in that top graph, it includes sort of recent implementations. So there might be a bunch of people who aren't using the technology yet at all, and many who have been using it for many months. So already we're seeing a significant reduction. In the bottom, if you drill into an individual's, the impact to an individual, you can see on the left, we have what's called pajama time, which is basically time doing work after hours. And that middle dotted line is when this user went live on ambient. And you can see that his pajama time went, the peaks here on the left are around 40 minutes. And after he went live, he's now on the order of 20 minutes of pajama time. So a really substantial reduction. And similarly for time and notes, you can just see a marked reduction in how much time this individual user is spending writing notes. We participate in a national sort of research and benchmarking survey called CLASS. And we now have the ability to ask a question about what tool the users are using. With this survey, it generates a EHR experience score. And this just demonstrates that the users of ambient have greater satisfaction with use of the EHR. So this is just recent data that we were able to demonstrate from our survey. This demonstrates that we've implemented the tool across our health system. Obviously, the purple is Portland, but we've worked hard to sort of get the word out and have champions in each of our regions. And so it's spreading throughout our health system. And then this also just demonstrates that we have all of our specialties represented. Primarily, primary care was an early focus, and they continue to be a major utilizer. But we've really been able to implement this with all of our specialties. And then finally, it was mentioned before by Dan, this is an incredibly rapidly evolving technology, and there's just a lot of exciting changes. Really, on the order of every few months, there's new features that come. And so we are, communicating and tracking closely the roadmap for the vendor that we're working with, a bridge, and anticipating the implementation of these additional features. And that is what I have. Let me stop sharing. And I would love to hear questions.
Yeah, great. Let's open it up. Chris.
Well, first I want to thank Dan too and Rebecca for such a just a thorough overview. I'm kind of a novice compared to the rest of you on this, so I was using Claude AI while you were presenting to learn as much as I could about the foundations of what you were all talking about, and then as I'm sort of parallel processing, and then to see what you just shared, Rebecca, about what Maine Health has done and what under your leadership you've actually implemented is really extraordinary. It seems super important and early, which I think is also super important, right? Because if we're early, then we can continue to sort of take advantage of the learnings and aggregate up. One of the things that my sort of experimenting as you were presenting, came to mind for me was whether or not there's an opportunity for Maine to make investments that would position the entire state, and it's particularly its rural healthcare networks, as a bit of a demonstration site for what's possible with this type of technology. And then I asked Claude, are partners helping to fund that sort of thing? And so I'll upload it in a minute, but it gave me several examples of demonstration sites in healthcare and examples of where partners are actually helping to pay the bill. And I just wondered if that's something our work group could play around with, especially given what you just showed us, Rebecca, about how far along you already are in building this throughout the entire state, maybe with a little bit of extra investment, prioritization. We could create sort of rural Maine as a showcase for the world on what's possible here. And that itself might attract new investment and lead to best practice and new models for patient care. Just, again, the benefit of ignorance and being the novice in the room is I can sort of ask ignorant questions of myself and the AI, and just wanted to offer that. And I'll upload the transcript as a PDF if any of you are interested in scanning it. It's pretty fascinating.
That's hysterical. That's great. And not an ignorant question at all. I think it's very much where a lot of minds are going. So thank you, Chris. And I don't know if you have thoughts about that, Rebecca, if you've thought more broadly or had conversations, or Dan Nygren, sorry.
Well, I'll just say that I think, just to dovetail on what Dan Carteret presented before, the impact of this technology on sort of enabling physicians and advanced practice professionals to sort of do their work and, enjoy their work, be more efficient, reduce burnout, reduce the likelihood that they want to reduce their hours or retire or what have you. As we're, looking at our older workforce, this could definitely be a key strategy to trying to retain people in the clinical workforce. And, it'll be a hard thing to measure. Certainly anecdotally, I hear from my colleagues of people who said they were going to leave or said they were going to retire, but this technology is enabling them to keep on working. And so I think there's definite opportunity there in terms of how do you push it out there and support it. I think it's going to be all about the sharing, the getting the word out, and the enabling the technology. And I don't know how easy or hard that part of it is. Dan Nygren may have some more thoughts on that, but I think it has great potential.
Yeah, thanks, Rebecca.
Great, thanks.
And Chris, it is an interesting idea. I think the devil would be in the details, as it always is in our world. One of the things that Rebecca mentioned was the tight integration with the underlying EHR. And when you start thinking about a singular platform that could service an entire region or portion of the state, undoubtedly you'd end up finding a variety of underlying EHRs. And so maybe that tight integration wouldn't be doable, but maybe that's okay. Maybe clinicians would be fine just going into a web browser or something like that, cutting and pasting the note into their respective EHR. Again, as long as all the privacy constraints and so on are met.
Yeah, I would reiterate, Dan, we've definitely found that in the telehealth world with the success of integration. You've got to make it as user-friendly as possible, but there's no way we're going to get everybody on the same EHR. It's just not economically or, feasible, but I do think it's doable.
The other thing I just wanted to underscore that Rebecca mentioned, she pointed to it as one of the highlights of her informatics career. And I know the reason, and that's because, frankly, within healthcare and healthcare IT, there's very few things that we roll out that our end users are happy about. Frankly, when we have a big go live, if we hear nothing, we consider that a success because we've not disrupted things and we don't have any angry end users. This, on the other hand, is one of the few times in my own career as well where, you know, we literally get love letters from clinicians about how transformative this technology has been. It allows them to get back to the reason that they wanted to get into medicine in the first place. And so it really has been dramatic. And I think that's reflected by the speed with which we've seen the industry adopt it. You know, Dan Ketterett mentioned before that, you know, it's pretty much the majority of organizations are at least dabbling in this now, if not fully on board. And considering that we just started 2-3 years ago, that's crazy fast for healthcare.
Yep. Yep. Not the usual 17 years, right? All right. Thank you, Sharon. Chris, you had your hands down now. Okay.
It does take us 10 years to implement, you know, new ICD codes, ICD-10 from, you know, from 9 to 10. So it's shocking that AI is moving so quickly. But I will say, Chris, I really am grateful for you making the statement that you made, because as I was looking through the questions that Lisa proposed or that have been proposed by this group, I thought, you know, one of the biggest barriers is going to be cost. And particularly for smaller rural providers in implementing AI products, there's without grant assistance of some sort, whether it be from the federal government, state government, private foundations, whatever, it's going to be very difficult to get everyone to the same place. But Rebecca, in terms of your presentation, I was curious about two things. If you're using the ambient listening for telehealth visits as well as in person, and if Maine Health has considered, because I saw a demo on this and I thought this is fascinating and really wonderful. One of the new AI products is a speech language conversion tool that takes your voice and translates it to your listener's language. So they hear your voice, but in their language. And then when they speak back to you, it comes into your language in their voice. And I thought, oh my God, this is great. And with some of the communities that we serve in Maine and some of the different groups that have come into Maine, into the welcoming cities, how great it would be to implement these kind of tools. And I wondered if Maine Health has considered that at all, because I would love someone to test it out first and then tell me that it's wonderful before we, you know, sort of make that recommendation to health centers who have much less in terms of money to invest in these products.
So thanks, great questions. First, I'll mention in terms of telehealth, yes, I have used it for telehealth. One of the barriers, however, is that we haven't, our current setup does not allow for use of headsets. So for people who do their telehealth in a room, you know, noisy room, but they're using a headset, that with our current setup, that doesn't work. But I do telehealth in my office. I close my door, and the key is that I have to put my phone on the desk so that it can hear the conversation, both voices. So it works for telehealth, but there's just that issue that we still have to sort through. It is fixable. In terms of the language issue that you raise, one of the interesting things is that our current vendor, Abridge, actually will translate for, I think, 28 languages. Now, what that means, it's not intended to replace having an interpreter in the room, but what it means is that you have your patient, you have your interpreter, they speak in their language, you're speaking in English, and Abridge listens to all of the voices and generates the note in English for the documentation, but it doesn't do exactly what you describe. And it sounds exciting. I haven't seen anything like that.
It's actually a Microsoft product.
Okay. I will say that you know, the level of comfort of the accuracy of the translation, you know, that will remain an issue, I think, for some time, unless you know, you really have great confidence in your ability to look at a transcript in another language. The other comment I just wanted to make, going back to the sort of the need for integration of the technology in the EHR, I will say that when UVM did their pilot, they were using a different version of a bridge that was not as integrated as what I demonstrated, whereby there was an app on the phone, and then there was the need for some sort of pasting. And even with that, the clinicians very much, used it and liked it a lot. So it is a barrier. Obviously, full integration is the goal and would be the sort of the desired end game. But I think if it's good enough, people would put up with a little less integration.
Yeah, Sharon, and the point I was going to make that Rebecca raised, but I'll underscore, is for this real-time translation that is starting to become available. The question that our interpreters have appropriately raised is, how can we ensure that that the quality of that translation captures what the intent was? And I don't remember any of the examples that our interpreter service routinely uses, but they even scrutinize all of the printed materials that we have for translations that these LLMs can do quite handily for us. But they point out how it makes some critical mistakes at times with medical subject matter. And so I think this raises, and the reason I wanted to underscore it, I think it raises an important point for our task force overall. I think we're going to need to wrestle with how perfect does this stuff have to be? Is good enough? And how do we wrestle with that? Because I could argue that not having any interpreter available and not having any tool for a patient who doesn't speak English is potentially worse than the risk that we might incur by having an occasional flub on the translation that's provided. But that's a delicate balance, and I think it's something that we'll encounter in other domains as well, not just healthcare.
Yeah, key question there. I guess it depends what the error is, right? It's always the question. And just related to that, another thing I saw in an article just the other day about AI is the ability of providers to quickly reach somebody and fix an error when it happens. Either the specific detail or the system's got a glitch or something like that. But we are getting close to the end of the hour. Actually, I had one more quick question for Rebecca. When you were describing the flow of, the phone, and then the last part, editing on your laptop, is that happening in the course of the visit, or is that pajama time at the end of the day?
Well, hopefully
neither.
It's happening at the end of the session. So it's happening while I'm eating my lunch or at the end of the session. So it usually that last step is not with the patient.
Okay. But it's in real time as much as you're
It
able
is. I will say that we are seeing measurable improvements in what we call same-day encounter closure. So all of you probably know that you don't drop the charge until you close your note. And some people are variably good at getting things done the day of the visit. And we're seeing very high rates of same-day closure because people are just not having to spend as much time finishing their documentation. They get it done the same day, and they're able to close those notes.
Mm-hmm. Yeah, that's great. Certainly contributing to provider less burnout and greater satisfaction, I would imagine. Yeah. Okay, great. Well, thank you for that and for the work that you're doing. And from there, we just wanted to transition to a discussion, I'd say work group members and guests, sort of some of these more general issues, again, starting from the 5 questions that we are charged with as a work group, but I pulled out, I labeled them incorrectly, 1, 3, and 5. It's really 1, 3, and 4 felt most relevant to this discussion. Where does AI offer promise for addressing Maine's healthcare challenges? Are there barriers that state policy could address? What might it take for Maine to emerge as a national leader? And Chris sent his apologies earlier. He had to sign off for a 1, but the idea really that he raised, particularly related to rural health, and how can Maine mobilize AI innovation where it's needed most, which is probably related to the other two questions as well. So we've had some start at that discussion in terms of, I think that good challenge and provocative question from Chris, is there an opportunity to make investments, particularly in rural? And I do think, I think Maine Health is clearly doing great work, and that is mostly with Maine Health providers, right? So, is there some way really to spread those learnings, spread this opportunity, both to rural providers in terms of FQHCs, but also rural hospitals that are not part of Maine Health, or rural hospitals that are not part of any health system, which are probably, I would often argue, are the least well-resourced and served, practices in the state.
If I could jump in a quick second, one thing that Rebecca didn't touch on was when we switched vendors, one of the key reasons, among many, but one of the important ones was the fact that the Abridge platform was significantly less costly than the initial platform. And though I think some of that may have been the different vendors behind them, the other is that these technologies are rapidly becoming more cost effective as there's competition unfolding. So I refer to it as a race to the bottom kind of thing. In some instances, I've seen examples of platforms that perhaps are not quite as sophisticated or robust as the one that we're using here, but that are almost free as a service that's offered. So I do think that again, you're probably not going to find it at the bleeding edge or leading edge of the technology, but as Dan pointed out, as the tech matures, I do think that it will become more affordable and more available. So even for the small providers who maybe don't have the resources to invest, I don't think it will be out of reach for them.
And I'm guessing there's probably sorry, Lisa, there's a lower cost per license the more licenses you purchase, right? So could there be buying power for the state of Maine to work with Abridge, for example, who may be pretty motivated to work with us and maybe be a leader in this for, reaching and impacting rural states? Could we look at a model like that?
So on that though, so they're all embedded in the EMR. So to the extent that Abridge is embedded in Epic, and say the FQHCs mostly use Athena or something else, how does that work?
But would they be willing to work with us to customize into other EHRs as well? Like, I don't know. I've never talked with the folks at Abridge before, but it would be an interesting conversation. I know a lot of our telehealth vendors will tell you, yeah, we'd like to integrate with.
But it's not just, is Abridge willing, is Athena willing, or XYZ EMR, right? It's really the EMR.
My impression, whether it's eClinicalWorks or Athena, they're all looking to
AI products,
looking at these technologies. I know that eClinicalWorks is integrating, and I don't know which vendor they're using, but one of the Intermed is using something, and they're on eClinicalWorks.
Both Athena and eClinicalWorks are embedding a lot of AI into their platforms. Those are the two vendors that attend our user groups regularly. So we've got to work with them quite a bit, and they've done presentations on sort of what they're working on. They're doing the ambient listening, the documentation suggestions, diagnostic suggestions, coding suggestions, all that kind of stuff. And even getting, some of them are starting to get into revenue cycle management. So revenue prediction, which is great. If you're a small provider, right? Revenue prediction is wonderful. Then we do have a few health centers on Epic. So it sounds like there's a lot going on with Epic. They do not participate in our small little HCCN because I think they're too big for us, I guess. And NextGen has their own sort of HCCN, so they also don't really participate with us. But those are the four vendors that we have for EHRs across the FQHCs.
Interesting. And can Rebecca or Dan, can you just give me a ballpark right now? Like when you pay for licenses, I'm sure it varies, by number and all that, but what order of magnitude are we even talking about? Is it like $100 a month or a year? Or? I'm sorry? Yeah.
Do you remember off the top of your head, Rebecca? If not, I can do a little bit of quick.
Yeah, I'm just hesitant because this is recorded and.
Oh, okay. Okay. Maybe if you can answer for more general, not from your experience, but in general, when providers do these things, is it, I just don't even.
I will say that when we started our journey, it was on the order of, I want to say, a couple thousand per physician per year. But it's come down. It's, I think, on the few hundred per month kind of thing.
I was going to say, I think that's similar to figures that
Yeah.
I've seen just in published literature, not from direct experience. But yeah, maybe 300 or 400 for some of the more expensive ones, and then less for others.
Just helpful to get an order of magnitude. Thank you.
I wondered if I could bring up, Lisa, an area that I really think the state is the only one that can help with in terms of policy. And that is that currently any liability for patient outcomes, right, lies with the physician who made the treatment decision. And there's no liability that goes back on an AI product and maybe the algorithms that we're using in the development. So it's the responsibility, right, of the physician to know, to be able to view what those algorithms are, to know the logic that was used in the development. And they're not always very visible. And so I think that there needs to be some involvement from a policy perspective of requiring that transparency, right? So physicians can say, I agree with the logic used or I don't, right? And so they know that going into using the product, or that there's some pushback on the developers of AI to say, you need to take some liability into the algorithms that you used in developing this. And did you use sound rationale, right, and logic in developing this, because it's being used for patient care, and outcomes are influenced by the potential recommendations, right, the product may be making for treatment or interpretation of results or what have you. And so I just think that's a scary area for me to think about, that it rests really on everything rests on the provider.
Yeah, it's a good point, Sharon, and certainly part of our discussion about risks and liabilities. And I don't know that we're going to convince the AI, or I don't know how you do that to sort of push some of it back to them. But to your point, at least about transparency and better understanding, how do you all, Dan and Rebecca, handle that?
We invoke the oft-used phrase "human in the loop." That you've got to maintain that element of review, in particular when things are going to impact the care provision to the patient. Dan, you mentioned in your presentation around the work involved with insurance, getting claims appealed and so on. One could make the argument that perhaps if an error is made there, it's a little bit less impactful, although maybe not completely. But that's not necessarily going to impact care, since that care has already been provided to the patient. Getting paid for it is, of course, important, but maybe that's an area where full automation might be more tolerable. I still think in these early days, even for instances like that, we're pushing for having that human level review. But let's be honest with ourselves also. And again, this goes to, I think, a broader conversation we'll probably have in the full task force. It's inevitable that this technology will get to the point where, perhaps not perfect, it's going to be good enough such that human review will end up being cursory at best. It's human nature, right? When I get in my car, and I can't remember if it was someone on the panel who used this example, but it's a very good one. When the little light in my rearview mirror goes off to tell me that there's a car behind me in my blind spot, I don't turn my shoulder anymore. I just know. And the contrapositive or whatever, if I don't see the light, oftentimes I don't turn my shoulder either. And I just move into the next lane because I've trusted that technology enough to this point that I've got a comfort level. I think we're not far from having these technologies get that good. And so we need to be careful about invoking human in the loop as the cure-all, because quickly, knowing how time-constrained clinical folks are, these reviews will be cursory at best. We're doing our darndest to make that not be the case, but we're fooling ourselves if we don't acknowledge that.
I know we've been doing some work with health centers on the development of their AI use policy, and one of the things that we've been really encouraging is that there's human oversight for all the AI that they're using. But I agree, I think at some point, particularly with certain things like lab and imaging interpretation, right? Those may become things that quickly, have a glance over, and then people are done with it, because it's really becoming pretty perfected as an area of AI. But I would love if you as Maine Health or anyone else on here has really looked at developing AI policies and sort of proper use, right? That sort of thing, responsible use, and are willing to share it. I think that those kinds of aligning the way we all as providers are using AI and treat AI internally and and to make sure we're using it responsibly would be really great. Because as working with a network of people that don't have necessarily chief operating officers and chief information officers and that sort of thing, it sort of rests with the PCA, right? And none of us are IT experts on trying to help them write these policies. And so any help in making sure that we're not missing anything would be great.
Yeah, and I'll say that for Maine Health, we don't consider ourselves the experts by any stretch. Rebecca and I co-chair our AI advisory committee, and we say it often in that group, we're all learning this together. I do think that there are good federal resources that can be tapped for this. Actually, maybe not so much federal, but national level. So there's an organization called CHI, which is an acronym that I can't remember now. But they've actually published a nice set of guidelines around the right approaches to evaluating these technologies for risk, for bias, for certain populations, privacy and security, those kinds of things. I do think have to be rigorously looked at.
I think having the peer learning opportunities and leadership coming from state, regional, national levels is going to be really important, because what we're seeing happening in DC, I think we're going to have to build you guys know where I'm going with this. We have to build these structures and build comfort zone, safety, security, privacy, all of the things. But they may not be able to come from a state level.
Yeah.
Yeah. And just to put a finer point, we're not going to see much from the federal level. That's policy, probably. Encouragement, maybe, but policy, I'm guessing not. I wanted to just go back to the questions of where does AI offer promise for addressing Maine's healthcare challenges? So clearly, ambient documentation, dictation, whatever you call it. Is there an approved word? It seems like ambient documentation is the latest thing I've seen, but is there a phrase we should use?
I think that's fine.
Okay, is one big one, and that comes up, clearly in every conversation. Is there a second runner-up that you've seen, whether it's remote monitoring, revenue cycle, in-basket management? Is there another, second or third that you think in that question would offer sort of most promise for Maine, and particularly, I'd say, rural healthcare?
The two that I've seen, Lisa, the most has been revenue cycle management. So predictive models around no-shows, around timeliness for getting claims paid, around likelihood of claims being denied, like it sort of pulls in all those pieces. The other one is where you're getting code assistance. So it's suggesting to you based on your note, and sometimes this is part of the scribing or ambient listening tools, where it recommends sort of a potential list of ICD-10s that might be attached to this claim, and a CPT or HCPC code that would relate to the service provided. And it usually will give you a list of the ones that might apply, and then you just select them in the demos that I've seen. And so I think those are the ones that people are most considering, because I think those are the places where the physicians are struggling the most. What, like in terms of finding sort of the correct ICD-10, to make sure you're, reflecting the appropriate risk group. So I think those are ones that I'm seeing in primary care anyway, as emerging.
Yeah, the one that I would add is sort of what I'll call chart summarization. These tools that can mine the whole record and give you that paragraph concise of here's what's going on with the patient, here's what's happened in the last year, here's where I found this information in the chart. I think there's a lot of excitement about the potential, again, reducing the cognitive burden and the sort of load of seeing that new patient in the ED, or the specialist seeing that new patient who's just gotten referred, and there's, oodles of records to review. There's a lot of potential there. That's a harder one, though, to think about from a state level. How do you provide, how do we support the smaller practices? Because that's going to be very EHR dependent.
Does that tend to be, again, an overlay of some vendor specific tool, like a bridge is the ambient documentation, or is that like something just embedded in Epic? Like what?
Yeah, well, that's what we're looking at is it's embedded. It's work that Epic is doing to leverage AI within the record. But I can imagine that it's a tool that an external product could also just mine. I mean, that's what it's good at. It's
I think that kind of stuff is being used in a lot of EHRs, that kind of logic to do gap analysis. Like, what are the gaps in this person's care or in this person's record? And I think it's being used that way in almost all the EHRs I've seen.
Yeah, another version. Mary has a hand up, and then we're going to start wrapping up a little bit. Yep.
I was just going to ask about whether you see a growing need to connect physicians to advanced treatment plans in cases where they're getting stumped, where there's a need to connect them to specialists or to clinical trials or other types of applications like that. I was just in a conference where I heard a statistic that now cancer clinical trials are up to 60,000 new drugs in trials right now, which is really a remarkable number and grows dramatically every day. And I'm just wondering if that advanced care strategy is coming to Maine.
We're seeing it being utilized in FQHCs where they're reaching out and doing provider-to-provider consultations with specialists because they can't get their patient to a specialist that has availability in the time frame that they need to get in, or that patient doesn't have the ability to travel to where the specialist is. And so
do you mean more like e-consults though, Sharon?
Yeah, that's what we have.
They're doing, e-consults, but then using the information from that e-consult to develop the treatment plan and actually providing the care themselves as the PCP that the specialist would have if the person could get there.
Okay.
Yeah.
Dan?
Yeah, I'm going to riff off of that idea, actually. And I'll say that I think it's actually not the healthcare systems or the providers that are going to be impacted. I think it's the general public, right? Just like when Google came on the scene, it was frequently referred to as Dr. Google, right? The patient goes and does their research ahead of their interaction with a licensed provider. We know that patients are now using the AI tools in exactly the same way. And so again, as these tools become perfected, and in an environment where we've got clinician shortages in a state that, as we've just been talking about, you can't get in to see a provider, let alone have one in your community. I think these approaches are going to be used by our population. And so if we see them become more and more perfected, or perhaps if there's a curated large language model that's based on, well-founded on clinical guidelines and so on. And frankly, these tools are already starting to be utilized in the community by our providers even. Why not patients themselves? And not saying that there's not going to be a need for clinical care and licensed providers in the future, but perhaps there's some degree of self-help that these tools could enable that might help where
Yeah. Well, I will say I have certainly had that thought related to acute/urgent care. If you consider the real crunch that we're in right now in primary care, the overcrowding of emergency departments, really the lack of access often even to information about what's appropriate for urgent care. And it's sort of a AI modern day version of the old nurse triage line, right? That helping guide people to, do I really need to go to XYZ? So that has crossed my mind in terms of a state tool. But to your point about patients, actually, Dan, I wanted to ask this group's thoughts or help specifically in thinking ahead to the next meeting of the overall AI task force. We're going to focus on healthcare. We're going to be tapping several of you. Dan's kindly arranged for this demo, initial right before that meeting. But we were hoping Dan Matz is trying to organize a panel of different perspectives, and one is the patient perspective. And I've kind of run up hard and cold around that one in terms of I don't know of a group, like sort of a consumer group in the state. I don't know, maybe you guys have one at Maine Health that is, sort of informed enough about this to speak from the perspective of a patient who has sat in the room where the iPhone is scribing the visit or has thoughts about this. Do you know of any resources or any existing groups or even individuals who you might recommend for that? Other than we're all patients and we should just be able to talk as a physician because we're a patient too, which is an argument, but.
Yeah, we do have an outreach network that we routinely sort of survey for their opinions on things. They're not necessarily curated, they're sort of self-nominating. So I guess I'm a little bit apprehensive of
Take my chances.
yeah, because it's an N of one, and if you happen to fall on an individual who just has a unique perspective, it might sway things one way or the other.
Do you have patients who have been engaged in this in developing your ambient dictation process or giving you feedback or anything like that?
I will say early in our journey, we actually, as part of our original pilot, we did patient surveys. We had them scan a QR code at the end of their visit, and I asked them 3 questions. And far and away, I mean, the response from patients was very positive. But that's not exactly what you're looking for. I think it's the rare patient, as I mentioned in when I was talking, we get consent from every patient. It is the very rare patient that says, no, I don't want to do that.
And Rebecca, is your sense that in those instances it's related to privacy concerns?
Yes, that is correct. And I will say that we often don't we don't say the word AI when we're describing, I'm using this new technology to help with my documentation. I review it, it'll record our conversation, and then I review the content before it gets finalized in your chart, and they love it. They say, oh, it's going to save you time. That's great.
It's a major issue, though, given what's come out on how much people don't trust AI and people have high levels of mistrust already about healthcare. And do we need to say the words? Should we be saying the words? How do we educate them? What kind of information do we give them about it, right?
Yeah, many patients say, oh, does it use AI? And I'll say, yes, it absolutely does. But the important thing is that I review the output carefully before it's finalized and make any corrections and edits. And they're like, okay, that sounds good.
The recording is not safe.
Yes, that's the other thing. Yeah.
The recording is not saved.
Yeah.
Interesting.
Yeah. And as you'll see in the demo that we do in a couple of weeks, it also does not include the schmoozing and the extraneous stuff. So
the chit chat, the article, the New England Journal article, should the chit chat be included or not? Yeah. Interesting. Yeah. Interesting perspectives both ways. Um, all right. Well, we're going to have to wrap up. I see, Sharon, your note, your coworker recently had a visit with a provider, asked to use a virtual scribe. Did they have particular thoughts about it? Would you have particular recommendations
I
for this?
think that they would be willing to share their experience if you would like. They went into Midcoast, one of the Midcoast medical practices, and
Maine health practice?
soon as they walked in, the provider said, "Would you mind if we used a virtual scribe to listen to this conversation and help document the visit?" And she was like, "Sure." It was the first time she had been exposed to it. I think she thought it was great. So I think that we could certainly find folks just within the people that we know that have had this experience that could probably talk about the experience of going through that too.
Yeah. Well, Dan Matz and I will touch base about this. We might take you up on that. I think we've got to, kind of figure out how we approach that. We don't leave out the patient perspective. And yet, I hear the perspective of one. So we'll give us some thought, and thank you, Sharon, for that offer.
Yeah. I will say that whole idea of privacy and what happens, behind the scenes to sort of the recording or the listener, whatever's listening, is what I hear most from both patients and providers about their concern about AI.
Right.
How do I know it's been deleted?
Right.
How do I know it's not out there?
And to clarify, Dan and Rebecca, the recording is deleted, but the information, I thought I heard in some other presentation that the information is actually de-identified, blah, 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 is the property of the vendor? No? I
No.
thought I heard that in some other presentation. No?
No.
Okay.
Yeah, I mean, the output is in the medical record.
Right. But I swear in some presentation I heard that the information, patient identifying information was stripped, but the output was the in the ownership of the vendor because that's how it learns. But not
I
yours.
can speak to what other contractual agreements are, Lisa, but the vendor does know if the provider goes and makes edits to
Corrections.
the document
Yeah.
so that in turn they can improve the AI algorithms.
Hmm.
But the raw data, the raw output is not saved in any way for the long term nor the recording.
Well, it's much more reassuring than the version that I heard. So it's great.
It's not saved, but it is used for development.
Correct.
So there is some period of time where it's accessed and used and then distilled in some way, and then it vanishes.
Only to improve
To improve the product.
Yeah. Yeah. All right. Probably a longer conversation, but we will have to wrap. Dan Matz, do you want to give a brief heads up on the plan for the June 4th meeting?
Sure, absolutely. I'll just jump in and say this was incredibly interesting. As a non-medical person, I've taken frantic notes and will be. I'm really excited to continue the conversation. 2 weeks from today, we are meeting. The task force is meeting at, I believe is it 110 or 100? 110, right? 110 Free Street in Portland. We are going to gather and from 2 to 4 for our normal 2-hour task force meeting, and there is an optional, and that's going to be a hybrid meeting. There's an optional, the hour leading up to that from 1 to 2 will be an in-person only demonstration of some of exactly what Rebecca described and what we heard from Dan and others of some of these really exciting tools. So we'll get to see it in action, which is really, really cool for me. So looking forward to seeing you all in person and getting to see AI on the ground.
Great. And we'll be having, again, likely some sort of panel talking, giving perspectives about AI in healthcare, and then a broader conversation again with the broader task force about these issues. And then the next meeting of the healthcare work group is Thursday. You can see the bottom of the agenda, Thursday, June 26th at 10 o'clock. So look forward to meeting with at least the work group members and perhaps some guests at that one as well. So thanks, everybody. Really appreciate it.
All right.
It's all great
Bye,
conversation.
everyone.
Thanks, Dan. Great job.
Sorry, I was just playing with it.
All right, we'll see you. Bye-bye.